That
Uh,
what? Yes, the game.
no, this time, I mean, we will, I mean, if we are number one seed, we'll play number eight, which will be
Yeah.
either, if I recall, the Heat, which is Miami, or Bulls, Chicago.
You start
Sure.
in Portuguese, of course, and I let you know when we our start.
Sure.
A Cissa também entrou, né? Cissa,
Boa noite.
tudo bem, minha linda? Como
Tudo,
vai?
tudo bem? E com vocês?
Também, super bem, super bem. Andrezão tá aí. Quem vai entrar, né, Kátia? Também o Angel?
Sim, o Angel vai entrar. Ele está no trânsito, mas vai entrar.
Ah, ok. Tá bom, tá bom. O Mil deve entrar mais tarde, que tá indo pro hospital, para variar.
Ou tá no hospital, ou tá no aeroporto.
É, dentro do carro, dirigindo, atropelando algum cachorro no caminho. Deixa eu ver aqui.
Doutor
É,
Angel vai entrar, doutor, mas não vai poder ligar a tela, ok? Ele já está aí.
Ah, é?
Isso.
Deixa eu ver aqui. Angel,
Ah, ¿cómo están? Buen día. Buen día.
bom dia, tudo bem, amigo?
Todo bien. Todo bien. Muchas gracias por la invitación. Ya estamos aquí.
Bueno, gracias, gracias. Eu sei como você está na
Gracias a
carreira.
ustedes. Sí, aquí ya listos para escuchar de cefaleas.
Sim, graças, amigo. Bem, eu vou fazer aqui os anúncios aqui habituais, mas antes eu queria agradecer uma vez mais aí Dr. Summer Narouze, que é uma sumidade aí mundial aí na área do tratamento intervencionista de dor, não somente intervencionista, mas a gente sempre fala do Narouze com muito carinho, voltado aí especialmente para as técnicas de ultrassom, né, guiadas por ultrassom na coluna vertebral. E é um prazer enorme aí tê-lo com a gente. Thank you so much, Summer, to join us and to make time for this. Thank you so much.
Sure. Thank you very much for having me. I really appreciate it. I see a few friends joining, so good evening, everyone. Actually, this is interesting. This is the first time that someone asked me to talk about wine.
Yes, yes.
I love wine, but I'm not an expert by any means. So
Okay,
I just
okay.
gotta share with you the wine that we gonna toast
Yeah,
tonight and why I like it or what's the story behind it.
okay,
So,
okay. Just a moment, Summer. One moment, please.
sure.
E agradecer a todos na mesa aqui que são conhecidos de todos aqui do Brasil, da América Latina. O André Mansano. Boa noite, Andrezão.
Boa noite, pessoal.
A Cecília Nobre. Boa noite, Cissa. Você já falou, mas boa noite de novo. Acho que ficou. Preciso ligar o microfone dela.
Boa
E
noite a todos.
boa noite. E o Angel, que está pilotando a máquina e já havia também nos
Sí.
cumprimentado.
Hola.
Sim, graças, graças, amigo.
Gracias.
Doutor Narouze, ele trabalha aí em Cleveland, onde mora, na cidade, no estado de Ohio, e é um professor aqui da universidade em Cleveland, e foi um dos fundadores da American Interventional Headache Society, e está no conselho de diretores da American Society of Regional Anesthesia and Pain Medicine, a ASA, e atua em diversos comitês da American Academy in Pain Medicine, em outras organizações internacionais de cefaleia e dor, por isso esse tema é importante aí, gestão intervencionista da cefaleia, uma subespecialidade em rápido crescimento. Na mesa aqui o Andrezão é membro, né, André, da Sociedade de Intervencionista de Cefaleia, André? Qual que é a sua que você participa, amigo?
Não, eu tenho a titulação, né, que eles criaram, a prova semelhante ao FIP, só que voltada para cefaleia.
Ah, que legal, cara. Bom, e para finalizar, sempre aqueles anúncios de agradecimento à OMED, à Genismed, que nos patrocinam aqui sempre, nos apoiam, e convidá-los mais uma vez ao Congresso Brasileiro da Sobramide. A Sobramide é a única sociedade brasileira de médicos de dor, voltada aí todas as áreas de tratamento, não só intervenção, clínicos, e vai ser o maior evento de dor do país. É o maior congresso, com certeza, da América Latina. Mais de 20 convidados internacionais, nomes importantes do Brasil todo, os principais nomes de dor do Brasil estarão lá. E nós queremos aí que todo mundo vá para participar. O Dr. Sami Narouze estará lá. Também vou agradecê-lo em alguns instantes sobre a aceitação do convite que ele deu aqui para nós aqui. E será no dia 26 a 28 de junho, ali no WTC, né, em São Paulo. Nós vamos ter também um workshop pré-congresso, que vai ser assim imperdível, não somente de intervenção em cadáver, como também outros, como onda de choque, radiofrequência. Então, é um evento que vai movimentar toda a dor em todo o país, em toda a América Latina, e é um evento que nós não podemos deixar de participar. Então, é um convite importante, e uma vez mais nós vamos sortear aqui mais uma inscrição para o Congresso Brasileiro. Summer, I would like to thank you once more for accepting the invitation for our Brazilian Congress in June. Thank you so much too.
Thank you.
And the time is all yours. Feel free to start. I'm curious about your wine. I know that's difficult to speak about that, but is part of the rules and is a good moment for us. Thank you a lot again.
Sure. No, thank you for having me here. It's a pleasure to join you. And as I said, there are many friends joining, so good evening, everyone. This was a very interesting request to talk about wine. I found it very refreshing because I did some reading, so I educated myself first. So I will share with you the wine of tonight. It's a I don't know if you can see it or not. It's a 1999 Shiraz. It's from the Barossa Valley from South Australia. It's called the Standish. I had 2 bottles of those, and the story behind is it. Actually, I got it for the year 1999. This was my first time to go to the American Society of Anesthesiology. I just like my 2nd or 3rd year of residency. First time to go to the ASA meeting, and I got a couple of bottles at that time. True story, funny story. Funny now, but not funny by then. The second bottle, my wife thought it's a cooking wine, and she used it for cooking. So it's okay. So this is a Shiraz wine from South Australia, at least this Barossa Valley. Just to talk about the grape itself, it's very dark skinned, and it came as a descendant of 2 kinds of grapes. The Narouze, which is the very dark one, and the other one, Mendoza Blanche, as you said, Blanche, it's white. So it was the parents of this Shiraz grape coming from those two plants, the Rosa and the white one, the Mendoza. This particular one is from South Australia. If you can see a small area here, it's called the Barossa Valley. This is a warm climate, so we'll talk about the different Shiraz. This one is called the Standish, and it's a single vineyard Shiraz from there. Everyone is confused about the names, Syrah or Shiraz. Both of them are the same. They are used interchangeably. Shiraz mainly if it's from Australia, but USA, we use the name Syrah, Syra, Syrah more. The origin of it, most stories, they believe that it has to come from the city of Shiraz in ancient Iran and the Persian Empire by then, based because of the name, and also because the Sierra name means black, Sia. In the Persian, old Persian language means black. So they believe that the stories are correct, that it came from Shiraz, through Syria, the Phoenician, through the Mediterranean, imported to Marseille, and then go to France. However, people feel that this is just fun story, made up stories, no one knows. They believe that the origin of Shiraz is actually from France. So it can be in a medium climate and hot climate, and the taste varies. And actually, the more you leave it in the bottle, they believe that the taste will be really different. So it's very dark, it's full-bodied, it's high acidic, high tannate in it. If it's in the cold climate, in the usually it's from October, the best month, October, November. But in the hot climate, like in South Australia, it feels more like spicy, nice, more like very dark espresso chocolate, even coffee taste. In the medium climate, it's more minty and black peppery. The more you age in bottle, they said, the best to drink it is to leave it in the bottle for 15 years. It feels more like earthy or even like a dark, fresh leather. So not to confuse you more, all those are the same name. I cannot pronounce even some of them, but Sierra, Shiraz, even some spell it with the X, Shiraz, Syra, Syrak, all of those are synonymous names. And those are the, especially this is the origin from the famous French vineyards. So it's time for a toast. Toast to the Brazilian Society of Pain Medicine, and to all my friends and everyone who's joining tonight. Again, thanks for having me.
Cheers, cheers.
Cheers. So the next half an hour, oh, it's nice. So for the next half an hour, we'll talk about interventional headache management in general, and too many modalities of treatment now. So I will focus on what I feel may be new to most of us, or the innovative, the stuff that's in the make now. So this is an article that put in LinkedIn many years ago, trying to promote pain physicians to seek some training and education in headaches, and why we are well suited to help treating those patients with intractable headaches. Traditionally, neurologists are evaluating those headache patients. They believe that headaches, it's the head. So the head part, the headache part is part of the neurologist. The ache or the pain part, when they don't know how to manage it, or for the intractable one, they ask pain physician to help. I think we shouldn't be working silos. It should be a team, multi-modality team approach for those headaches. It's the first one or the gate will be from the PCP, primary care physicians, and then neurologists, pain physicians, psychologists, psychiatrists, physiatrists, physical therapists should be working hand in hand. Why I started to gain interest in headache? Because we lack formal training during our residency and fellowship. And headache in general, special migraine, are very prevalent. So if we look at this illustration by the CDC, it's a survey, you can see the prevalence of migraine on the left here. In males, it's roughly 10%. Females, it's like 22, 23%. Cervical or neck pain, it's again about 12% in male, 15 or 17% in females. And on the far right side of the screen, facial pain, it's like 5% in male and almost 10% in female. This column is the low back pain, 25%, 30%. So if we added the prevalence for migraine, plus neck pain, plus facial pain, orofacial pain, you will see that this far outnumber the chronic low back pain, which we devote most of our training during resident fellowship in addressing chronic back pain. I'm not downplaying the chronic back pain issues, but I was saying that headaches are more headache, face pain, neck pain together are more prevalent than back pain. So that's why we started our new society a few years ago, and we started our new journal in 2020. And the idea is to educate neurologists about what we can help their patient with, the intervention part, and educate pain physicians about the medical part, how to make an appropriate diagnosis. The most critical step in the management of headache disorders are number 1 and 2 and 3 is to make an appropriate diagnosis, because the management is totally different. Management of migraine headache is totally different than cluster headache, than tension headache, which is even more prevalent. And definitely we need to have the tools and the education to know how to exclude or rule out secondary headache disorders. So in general, we can say totally 14% of adult, male and female, we said 10 and almost 20, are suffering from severe headaches. 14% from neck pain, 5% from face pain. 20% of all those patients, they do not respond to conservative therapy, meaning medical management, physical therapy, non-intervention therapy. So we're left with 20% out of those patients that they need our help. Headaches is very prevalent, and it's more common in the middle-aged females in the most productive years of one's life, between 30 and 40 years. They need to go to school, they need to work, they need to attend to their family and the kids. So it's very disabling and have a significant burden on the patient, on the family, and on the community in general. So in the middle-aged females, migraine actually is the leading cause of years left in disability. In general, it's the second leading cause of disability. The World Health Organization, WHO, said up to 4% of the world globally, 4% of the population experiencing chronic pain. 50% of them severe impairment. 20% of them do not respond to the available pharmacological agents. So to put those numbers into perspective, this is published in the RAPAM. I published it 2 or 3 years ago. So those numbers are a little bit more. But in general, we say 45 up to 47 million patients in the USA only suffering from migraine. By now, I'll say up to 500 headache specialists, neurology headache specialists certified by the United Council of Neurological Subspecialties. This is the body that gives the board. I had to convince them in 2006. I sat for this board. I was the first. I'm sure now there are few anesthesiologists, they have it. to get the neurology headache board certification. And then a few years ago, we started, because you cannot sit for this neurology headache board unless you are either neurologist or you fulfilled the completed 1 year of headache medicine fellowship. So for us, we started to have courses, education, and didactic workshops, and the American Board of Headache Medicine. For now, we have 30 specialists. Some of you I know for a fact, Dr. Andrea Manzano got this board a few years ago. So we're doing those courses twice a year, usually in Chicago in the spring and the fall. The next one is in May, and the board, usually it's Saturday, Sunday, and the board exam on Sunday. So I'm gonna go in details into migraine, just to give you the an idea about the impact of migraine and why we need to, there's a gap in treating those patients. Primary care physicians are ill-equipped, and for some reason, neurologists, not all of them are headache specialists, and neurologists traditionally, they like to take care of stroke, movement disorder, seizures, and headache patients, they don't have a genuine interest in headache among neurologists. So there is a gap in treating those patients that I think we need to fill. So about 12% of the general population, again, males and females, suffering from migraine, said up to 45 million. 25 of the female between 30 and 50 having migraine. 25. So 1 out of 4, they are having migraine headaches. 5% of the general population, they have chronic daily headaches, which could be chronic migraine daily headache, chronic tension headache, or other headache disorders. So 5% of the population, they have headache every single day. If you have headache every single day, this automatically means it's medically resistant. It's not responding to medications. That's why they have it every day. Here comes the role of the interventionist, interventional headache management. Up to 15, 16 millions. So again, to have an idea, overall idea, 38% of the population will have symptomatic low back pain versus 47% when symptomatic headache. What's the economical impact? It regardless, I mean, this is dollar value, but the psychological impact on the family, the mom cannot attend graduation, cannot attend sports activities, cannot participate in family event. This is really huge. Missing school days, missing work days. So if we said 23% have migraine, 50% of them are severe migraine headaches, this is roughly $1 billion a year. Very significant. Migraine disability, more than 0.5%, they require bed rest. Actually, some will argue that this is the best treatment. Just go, if you can afford it, go in a dark room and try to sleep, put ice in your head and try to sleep, stop any stimuli around you. But you cannot afford this, or most of the time you need to work, you are doing something. And as I said, it's the second leading cause of disability. Migraine progression. This is an important slide. Out of those that they have chronic migraine headache and then they transition to chronic daily headache, it's mainly because 10% they cannot tolerate their medication. Whether up to 2% reach the maximum safe effective dose and they still have frequent headache, or they could not tolerate the medications. And that's why this is the call for either new pharmacological targets or non-pharmacological interventional options. So again, I will talk about the new or the advanced interventional treatment modalities for some primary, some secondary headache disorders. So in general, those are the headache disorder that they got referred to a pain specialist. And we call that the interventional amenable headaches. Chronic migraine, refractory, medical resistant, cervicogenic headaches, cluster headaches and other trigeminal autonomic cephalalgia, hypotension headache, SIH headache or posterior puncture headache, and then cranial neuralgias and occipital neuralgia. So occipital headache, for you who heard me before, I always stress that, if we pain physician want to be a neurologist or headache specialist, want to be headache specialist, we need to be careful with the diagnosis. Occipital headache is not really a diagnosis. Occipital headache is a symptom. All what we say that the patient has headache in the back of the head. You have to rule out primary headache disorder and secondary headache disorder. It really breaks my heart when we see that the patient has occipital headache, we jump into occipital nerve block and we label the patient occipital neuralgia merely because the patient has headache in the back of the head. Actually, I'll argue that the most common cause of occipital headache by far is migraine headache. Rule out migraine headache, imaging to rule out second headache disorder, conservative therapy, which is over-the-counter analgesics, then migraine-specific medications, if it's migraine. Occipital neuralgia, you can easily, occipital neuralgia, it's like the mirror image for trigeminal neuralgia. You cannot really miss a true occipital neuralgia. You tap on the occipital ridge, you feel severe electric shock, allodynia, hypersensitivity. If they turn their neck and it triggered this sharp pain, then it's C2 neuralgia, or impingement on the C2 dorsal root ganglion from bone spur, arthritis around the C1, C2 joint, which is atlantoaxial joint, dislocation. So neuropathic pain, typical neuropathic pain, is occipital neuralgia. To make an appropriate diagnosis, occipital nerve block, relief from occipital nerve block. And then you have about long-term relief. Relieve the entrapment if they need surgery because of the neurovascular pressure in the area, or you can try pulsed radiofrequency ablation, cryoablation, neuromodulation in general. Usually the last resort will be an occipital nerve stimulation. On the other hand, from the other end of the screen, myofascial pain, muscle pain. So usually if this is muscle pain, tension, it classifies under tension headache associated with cranial myofascial pain. It's classified as tension headache. You try muscle relaxant, NSAIDs, trigger point injection, botulinum toxin, although historically it is not too helpful for tension headache. It's more helpful for chronic migraine prevention. And it's FDA approved for chronic migraine prevention, not for tension headache. Then in the middle, pain with cervical movement, causing referred pain here. If it's up there with rotation, then it's C2 neuralgia. If it's lower, then it's cervicogenic headaches, which is pain stemming from the cervical spine. And we'll have a different algorithm for this. So occipital neuralgia, we're all familiar with the technique. I'm not going to spend time there. Some still doing landmark-based, which is fine, but it's really painful to do it high there. The skin is painful. Touch the periosteum is painful. Making a wheel from the mastoid to the occipital protuberance it's painful. And those are young females, young girls having this injection frequently. It's painful. Also, traditionally, you hit a bone and then you withdraw a little bit, you inject. Be careful because there might not be a bone. If the patient has history of craniotomy, and there are 2 or 3 case reports in the literature about coma following this injection because you injected into the CSF after history of posterior craniotomy. Actually, one of those case reports were ear infection and posterior mastoidectomy, and this was lesser occipital nerve block. So ultrasound, the suboccipital area is, I think it's easy. You just need to see it once, do it twice, and then you will master it. Different muscle layers. You cannulate the space or the fascial plane between the semispinalis capitis and the inferior oblique muscle. This is normal. You just see few bubbles. Sometimes you see the pulsating branch of the occipital artery. On the other side here, this is a pathological nerve, donut sign, significant swelling edema around the nerve. This is a patient who hit her head back of the head in the edge of the top, and just severe allodynia and hypersensitivity and Tinel sign. We injected steroids and then botulinum toxin in the muscles, semispinalis capitis, inferior oblique to relieve the pressure on the nerve. With ultrasound, you start from the C2 spinous process, C1 arch, tilt the transducer to align it from the spinous process to the lateral mass of C1 to align over the inferior oblique muscle on the long axis of the inferior oblique muscle. So the idea is to have the long axis of the inferior oblique muscle, so it looks more blackish, more striated muscle fibers, long axis, although the ultrasound still in the short axis view, but this is long axis of the muscle, short axis of the semispinalis capitis. So this is the superficial muscle, so to be short cut in it. However, it will be a long axis cut of the deep muscle, which is the inferior oblique muscle. Sometimes you can trace the nerve, you see it swollen, you can appreciate some nerve bundles. This is the nerve entrapped inside the semispinalis capitis before it pierces the trapezius aponeurosis, and still it's usually here it's very difficult to see. This one, because it was very tender to touch, and you can see why, because it is entrapped in the suboccipital muscle. Sometimes you will see a big artery pressing on the nerve. You can see the honeycomb appearance of the occipital nerve here. And this will illustrate you the difference. I mean, in order to see the facial plane and cannulate the facial plane between the semispinalis capitis inferior oblique muscle, you need to align your transducer as I showed you, so you can see a long cut in the inferior obliquus muscle, short axis cut in the semispinalis capitis. In most of the patients, especially if they don't have thick hair will create lots of artifacts, especially in Asian population with thick hair. You might have lots of artifacts. You might not have a good picture like this. Most of the patient, you will be able to see between C1 and C2, be careful, there is no bone. There is a big gap between C1 and C2, so you can see the dancing spinal cord here, the exiting C2 dorsal root ganglion. More lateral, of course, will be the vertebral artery. So you have to be careful if you go out of plane. You have to check the depth, mark your needle. If you want to come in plane, it's safer if you feel more comfortable that way to see the tip of the needle. So just this is a safety precaution that you monitor your depth. If you use out of plane, which I do, you have to do maybe hydrodissection as you go, so you know exactly where are you, and then finish the injectate here. Unless you want to do selective C2 DRG, which we'll show it later. Cervicogenic headache, it's pain stemming from the upper cervical structure that's innervated by the first 3 or 4 nerve roots. Signals from the primary neuron, synapse on the DRGs. Second order neuron will go up. The same way, signals from V1, V2, and V3 go down to the trigeminal nucleus caudalis. So the second order neuron can carry signals coming from C1, C2, C3 territory, or from the trigeminal territory, V1, V2, and V3. So differential diagnosis, atlanto-occipital, atlanto-axial, C2-3 joint, C2-3 disc even, upper nerve roots, upper neck muscles, posterior cranial fossa, and vertebral artery. This is the differential diagnosis of occipital pain. You have to rule out the other issues. However, for the pure diagnostic or definition of cervicogenic headaches, usually it's the upper ones, the upper few ones. The muscle, we said it's coded under tension headaches, and posterior fossa tumors will be secondary headache disorder due to mass lesion, and vertebral artery dissection or thrombus or aneurysm, it's more under secondary headache due to vascular lesions. So those are the true causes of cervicogenic headaches. However, clinically, you want to rule out the other headache disorder that cause referred pain to the occipital area. So cervicogenic headache. We said it's part of the occipital headache. So occipital headache, we rule out migraine, you rule out secondary headache disorder, you exclude occipital neuralgia, you exclude myofascial pain, and you left by pain from the cervical spine. Pain when you nod, you fix the cervical neck, and only nodding, which is very rare to have isolated arthritis in the C0, C1, which is the atlanto-occipital joint. Usually it's trauma, accident, metastasis in the condyle, bony metastasis. So usually they need surgery. I used to do, not use, I mean, I did just a few of those injections, but usually there's no need, it's very risky. Usually the cause is either from atlantoaxial, which way far more common in whiplash injury, in rheumatoid arthritis, in Down syndrome, gouty arthritis. All this will cause pannus and synovial inflammation in the atlantoaxial joint. This is one of the most common reasons of whiplash injury. And this one is rotation of C1 over C2. So you ask the patient to flex the neck, support the lower neck, and rotate C1 over C2. It will trigger the pain. And if there is a bone spur or a posterior inflammation posteriorly, or bone spur posteriorly, it will irritate the C2 DRG, and you will lead to C2 neuralgia. Then pain coming from the lower will go lower. C2-3 by palpation. Again, this is the whiplash injury. We know very well the innervation of the C2-3, so you can do third occipital nerve block. That's why we call it third occipital headache and RFA. Innervation of the atlantoaxial joint is more challenging because it comes from anterior and lateral, not posterior. So it has to be lateral, and it's unless you do intra-articular RFA, which is hit and miss. Atlanto-occipital, I just want to show you the anatomy. This is the vertebral artery. It's spanning behind or posterior to the atlanto-occipital joint. So it might not be feasible, even like this picture here, it was ultrasound, to access the AO joint. So this is the AO joint. Usually the vertebral artery is lateral to the C1 mass, which is this one. And then it curves medially so it can go to the foramen magnum. So this is a picture from angiogram. So you want to target laterally. Again, it's very rarely indicated. I don't see really a good indication for it unless the surgeon insists to do it prior to fusion. On the opposite, atlanto-occipital, this is this one. This is a healthy patient. You don't see this joint nicely gapped like this when you need to inject it. Unless it's inflammatory, AA ankylosing, or I mean inflammatory synovitis. You can see a good joint space. Usually it's in elderly women, and it's very, very sclerotic. The vertebral artery is lateral. Sometimes there is a curve, so you want to target the lateral third of the joint. So this is the joint space on the other side. So you mark the lateral border. This is the medial border. C2 DRG is here. You want to target here. Little bit medially, they will not let you do it because you will touch the DRG and they will say a big ouch, or you can get C-cell. So this is a target view, the lateral third, junction between the lateral third and the middle third. This is interarticular. Very important to be selective interarticular. It's almost like a rudimentary discogram. Because if you spell outside, then you are blocking the C2 nerve root and dorsal root ganglia. So actually the patient might have C2 neuralgia or even occipital neuralgia, and you numb the nerve. That's why the patient has relief. Then you send the patient for surgery to fuse it. Patient will come back because the original pathology was in the occipital nerve or the occipital nerve root. So for the first one, the diagnostic one, I strive to be truly intra-articular. If later on you want a therapeutic, it doesn't matter if you have spillage outside. C2 DRG is big. It's really big. This is the dorsal ramus, which will curve below the inferior oblique muscle to ascend as the occipital nerve block. This is the ventral ramus, which will curve lateral to the joint, supply it from anterior. So actually the innervation of this joint is mainly from the anterior division. And this is the vertebral artery. So this is the joint, the capsule. So you want to put your needle somewhere here. I don't know. I mean, it's can be challenging. Vertebral artery is lateral, and then it curves. This is the C0, C1 joint, and then go into the foramen magnum. DRG, posterior ramus, vertebral artery. So ultrasound, can you do it? Yes, you can, but you shouldn't be, unless you just do it. If you can't see much with the X-ray, but I think you have to complete the procedure with fluoroscopy to make sure the tip of the needle in the joint and to monitor the spread of the injectate. Here, I use the ultrasound to pick a nice space in the posterior capsule of the joint between the C2RG medially and the VA. So I feel more comfortable that I'm away from both structures. Here you can see the needle indenting the muscle. Might be aiming to the VA, you just align it more medially. This can be helpful, and this is a patient of mine. I mean, you ask the patient to open the mouth, close the mouth, orient the fluoro, you cannot see much. So you place the needle with ultrasound, and in the lateral view, you complete with fluoroscopy. Cervical facet, I would say the only innovations here that we are more and more comfortable doing the RFA, they are Trident needle that capture a bigger area. Although in the neck, usually you don't need a bigger lesion, maybe in the thoracic, because the anatomy is variable. The lumbar area, you need a bigger lesion, maybe with the third occipital nerve, because the anatomy is variable. But with the other medial branches, one regular unipolar lesion will be suffice. This is a busy slide, but this is to summarize the recommendation by the multi-society guidelines for cervical facet block and RFA. I can share the presentation with the leadership, and they can share it to everyone. And actually, it is on my webpage. I want to emphasize that for the neck, we need to respect the neurovascular structures. There are tons of vessels compact in a small area. That's why I always insist of using contrast. Proper contrast, this is the proper spread, 0.1 ml. If it's striated muscle, then you are superficial in the semispinalis capitis muscle. So it's not really specific, especially we recommend with the diagnostic block 0.3 mLs or 0.5 at the most. You don't want to inject it in a muscle. DSA. So this fusion, this is a patient with adjacent liver disease. Usually with fusion, you don't need to do a facet. You can if you truly believe it's anterior fusion and the posterior element, it's what's causing the pain. But those are the level above documented with DSA. Be careful of the vertebral artery. It might have a variable anatomy, tortuosity here and here. So if you have a CT scan or MRI, usually by the time those patients see you, they have CT or MRI. Go over the images, educate yourself about the vertebral artery. Actually, one side might be different than the other side, because even with perfectly placed needles by fluoroscopy for the third occipital nerve, you might injure the vertebral artery. Ultrasound is very helpful tool in the neck. I'm a big fan of ultrasound in the neck, not much in the low back area at all, but in the neck, I do almost everything except RFA for medical legal reasons, because not too many physicians are using it in the States. So if something happened, I always save fluoroscopy imaging. Again, no need to go into details, but I think all of you are familiar with them. The idea is to identify, come to this view, the peaks and the troughs. The first bone will be the C2. The transverse process of C1 is very deep, so sometimes you miss it. C2, the first articulation, the third C2, 3, more lateral to it or superficial to it, will be the third occipital nerve. And then you scan more caudally to identify this. You can do it in the short axis or long axis. Lots of vessels everywhere. That's why check Doppler. couple of years ago, more 2020, we did this systematic review and meta-analysis between all the published report with fluoroscopy only with ultrasound. Ultrasound was non-inferior when it comes to the access of the block, the pain relief. However, performance time, it was better, and no incidence of vascular complications. However, you can argue that those who publish those reports are experienced. That's why the performance time is better. However, I argue it saves me time because when you put an ultrasound transducer on the lateral neck, this is the image you see. It's not from the other side. With fluoroscopy, you have to align your X-ray. You have to be very familiar with the paradox effect that you are targeting this side, not the other side. And if the patient moves or cough or sneeze, you have to adjust the CR. So it helps, but it needs a learning experience for sure. I want to spend a couple of minutes on this C2 DRG. We have been working on it since early 2000. I believe that the C2 DRG, it gets supplements or innervation from C1 as well as C3. So if you block the C2 DRG, actually you're blocking the upper 3 cervical nerve roots. So you are denervating the upper cervical cord from all the pain signals in the back of the head. I found it much more helpful than just pure occipital nerve block. It lasts longer. You can do DRG at this level. I prefer still pulsed DRG. You can stimulate neuromodulation at this level. And now with ultrasound, you have more confidence. Where is it? And you can use both ultrasound and fluoroscopy. So I have to thank Sergi. He did this illustration for me. So if you want to cannulate the space between the semispinalis capitis and the inferior oblique muscle, this will be the greater occipital nerve, terminal branches of the third occipital nerve medially. Tension, and in this case, it has to be in plane. You cannot want to take a risk because a couple of millimeters deep, it will be the canal. Just to go through the inferior oblique muscle, you will inject just 1 mL, you will flood the area around the C2 DRG. Again, this is the orientation of the ultrasound transducer that I was telling you. So between the two muscles, you will target the branches of the occipital nerve. Deep to it, it will be the DRG. The DRG. So we dissected few cadavers. 1 mL of methylene blue flooded the area. This is the arch of the C1 bone. DRG. This is the vertebral artery. So you can argue that this is more or less retrolaminal or fascial plane deep to the inferior oblique muscle, which is fine, whatever you want to call it. You can see, and this is not too much contrast. You have a spread to the epidural space. Actually. So I'll try to run this video. This is the orientation of the ultrasound transducer. So you can see the long axis of the inferior oblique muscle, semispinalis capitis here, the greater occipital nerve in between them. In between the semispinalis capitis and the inferior oblique will be the greater occipital nerve block. I used to call it suboccipital block 1. People get offended with new terminology. So let's make it simple. Occipital nerve block and C2 DRG block. Chronic migraine. The most important step is to make the diagnosis. Rule out secondary headache disorder. Medication overuse headache, which means if you take analgesics more frequently, even acetaminophen, non-steroidal anti-inflammatory, if you take them more than 10 or 15 days a month, you run into medication overuse headaches. Strong opioid, we recommend only 5 days a month. Triptans, which are specific migraine medications, 5 to 8 days a month. Rule out MOH, treatment of MOH, which is usually weaning off the offending medicine. Then if it's not MOH, you can try, and failure of conservative therapy, all the preventive medications, whether the anti-seizures, antiplatelet blockers, the new CGRP medications. I mean, we can give another talk about medical management of migraine, especially with all the new CGRP medication. I'm not sure if they are available in Latin America or not, but it's a breakthrough in the field. Botulinum toxin injections approved for chronic migraine prevention, IV infusion, IV cocktails, IV lidocaine, ketamine. Now with the new development of a multitude of non-invasive neuromodulation, I'm a big fan of them. We always want to do the aggressive stuff, the more invasive stuff. Still minimally invasive, but this is totally non-invasive. We have a slide about. You can try them at any stage if medical management failed, or even with medical management, because they are very innocent. What's the worst case scenario? And then up to 20-30% of patients with migraine headache, they have autonomic features. It's not autonomic, trigeminal autonomic cephalalgia like cluster headaches or hemicrania continua, but still some of them have autonomic features. They will respond better to parasympathetic block or sphenopalatine block. If they have occipital pain, which is the majority, you might try occipital nerve block and then see the response, or you do neuromodulation. Non-invasive neuromodulation. The best for acute migraine therapy, actually this lowest one, remote electric neurostimulation. Something you put it on the shoulder and it stimulates the pain modulatory pathways and inhibitory mechanisms. Then there is the supraorbital, we call it transcutaneous neurostimulation. It's like a TENS unit specific for the supratracheal supraorbital. There are different companies from them. There are tiara around the whole neck, head, or only here. Non-invasive vagal stimulation, which could be in the ear or the cervical part of the vagus. It is FDA approved for acute and chronic migraine as well as cluster headache. It's one of the few FDA approved indications. Transcranial magnetic stimulation is amazing for chronic migraine prevention. And of course, depression, maybe Parkinson's, other stuff. But it's an expensive modality. It's not available everywhere, but it's very helpful. All those are, the side effects are really maybe cost you some money. I always joke, it might hurt your pocket, but it really does not hurt, or there's no significant adverse events. It's worth to try it for sure, if it's covered or if the patient can afford them. This is a new, a relatively new systematic review and meta-analysis of the RCT trials for all the neuromodulation techniques for acute and chronic migraine prevention. To summarize, the most effective acute treatment was this REN, remote electrical neuromodulation for acute prevention. For chronic migraine therapy, it was, believe it or not, occipital nerve stimulation, although the original RCT trial, the three of them were equivocal, but because the primary outcome was poorly selected. And again, the tiara or the supraorbital transcutaneous stimulation, the transcranial magnetic stimulation, also all those are chronic migraine prevention. Occipital nerve you can use over-the-shelf spinal cord stimulation, because the newer modalities are not FDA approved for headache yet. This is off-label for headaches. Some using surgical. I use it if there is migrations once, twice, then the surgical lead is more helpful. Where to put it? Now we believe that the highest, the better, because you capture the terminal branches of the nerves. The idea is to block the signals to the upper cervical cord. So higher here is better, which it's true peripheral nerve stimulation. If you put it suboccipital here, it's sub-Q. Then it's more like peripheral field stimulation, unless you intentionally, so this is sub-Q, unless you intentionally put it in between the two muscles, which would be true. But this is challenging. There is no need. I think at the ridge, it's fine. The only risk is if you don't do it correctly, you risk erosion through the skin. So when they analyze the RCT trial for the occipital nerve block, there's lots of adverse events. Most of them are related to the PNS implant itself, the hardware, the technique, and the blue are the naive surgeon or implanters. They had experienced 0 to 5 occipital nerve implant prior to this study. So definitely need experience, and you need a tool designed for this application. 40% lead migration. Friction was 11% in the unexperienced hand. It's very significant. If you have to do another surgery in 1 out of 2 patients, this was totally unacceptable. That's why the FDA did not approve it at that time. So now there are renewed interest in occipital nerve stimulation. There are new devices in the market, and now we believe that maybe we should target both circuits. The trigeminal circuits, the most accessible is the V1, the supraorbital nerve, and the occipital circuit. There are new devices now, very small generator that we implanted behind the ear, in the scalp behind the ear. Integrated, attached already to 2 leads, a long one that will go from here around to capture the supraorbital nerve, and another one for the occipital nerve. It's 1 unit. You still need a trial because the FDA required a trial. So we're doing a large multi-center study in the USA with almost more than 20 or 25 centers. Very excited about this modality of treatment. Last month, January this year, we had the preliminary results from the cohorts from the proof of concept study before the start of the RCT trials. Again, we're modulating the occipital nerve, so the trigeminal cervical complex, as well as the trigeminal vascular complex. When we reviewed the available literature, we found that although they are not RCT trial was only for occipital nerve stimulation. Occipital nerve and supraorbital nerve, there were only case reports, cohorts, retrospective trials. There was a signal that this might be better. And this is what triggered this new company that using a new device. We published the preliminary results. The monthly migraine headache reduction was really significant. 12 days or 11 days is huge. Just to give you a perspective, to put it into context, the new CGRP medication that was FDA approved for migraine prevention decreased migraine headache days by 3 days a month. So this is too good to be true. You can say that maybe because those are hand-selected patients for the pilot. That's why I'm excited about the randomized controlled trials. The gold standard is still RCT trials, large RCT trial with what I say loose inclusion-exclusion criteria to mimic real-world data. We don't want to hand-pick the patient that we know that they will respond well. 80% reduction of 50% of the headache. So this was the primary outcome that was chosen for all those negative or equivocal RCT trials. Now we know that the primary outcome should be monthly headache days reduction. Satisfaction was amazing. So this is the picture, the 2 supraorbital, 2 suboccipital, and you cannot really see them. And even the generator, it's like a quarter behind the ear. It's covered, totally covered with the hair. SPG, I will go through it quickly because this should be a different new talk. I mean, a solo talk, but in general, this is not new. I will share with you the innovation in the SPG intervention. In the early 1900s, this was described for at that time what they believe it's called sinus headache, nasal headache, or sphenopalatine neuralgia. Then they start to do it in cluster headache and sphenopalatine block. The cluster headache was well recognized at that time. It was helpful in the acute or episodic cluster headache, but not the intractable chronic cluster headache. Our group did the radio frequency for chronic cluster headache, which was helpful. This is in the 2008. And then more lately, there is publication about using even with the nasal approach for posterior puncture headache, intracranial hypotension headaches. This is very fascinating without going into much details. Just to let you know, there is parasympathetic fibers. This is the neuron. The only neuron that synapse is the parasympathetic. Then there is sympathetic innervation that pass through the ganglion, and there is somatosensory from the maxilla V2. So In this small cave, you can modulate the parasympathetic, the somatosensory trigeminal complex, and sympathetic if you want. Many different approach. Definitely the easiest and the most accurate is CT guided. You can see the opening is very, very small. So sometimes it's very challenging to do it with fluoroscopy. DSA, because of the inferior palatine, the maxillary branches, the inferior palatine, it's very vascular. You can see here with CT guided, the needle tip is exactly the size of the foramen. That's why when people start to describe it with ultrasound technique, I'm not sure you can be here. They always describe that the needle is somewhere outside the pterygopalatine fossa, which will be the infratemporal fossa, which will be mandibular branch block, not maxillary. There is nasal approach. We can talk about the pros and cons. There is definitely some limitation to the nasal approach. Might work through different mechanisms other than the actual SPG. Neurostimulation for the SPG. People were very excited about it. We did a proof of concept pilot study for chronic migraine, chronic cluster, acute treatment of chronic cluster. But unfortunately, the large study, although it's good in Europe, the one in USA, they stopped it because of lack of funding and the company went bankrupt. At that time, I was using, again, over-the-shelf medications, lateral view into the fossa, tunnel it. Now there is, in Europe, they did this RCT trial, which was really, really very promising through a microstimulation device. You can see it go. We do a CT scan prior to the procedure to make sure that it's even accessible. They go with a small incision in the upper gum, and this small mini device, slip it into the pterygopalatine fossa, you screw it into the bone, and again, it was very effective, but the multi-center study in the USA was terminated because of lack of funding. I think this is the newest in the literature that I can find. The new device, but the concept we did it years ago, injecting Botox, botulinum toxin, into the pterygopalatine fossa for the SPG for cluster headache or migraine. At that time, as I said, it's not. Sometimes it's very challenging, if not impossible, to reach the pterygopalatine fossa with fluoroscopy. We didn't know the actual dose, the volume. I have patient that the medication went through the inferior orbital fissure. They got diplopia, abducing nerve palsy for a couple of months. But now with this device, through navigation, you upload the CT scan of the patient and use this navigation guided device. And this is like a gun. You can target the pterygopalatine fossa, exactly inject few units of the botulinum toxin. This group in Europe claimed great results, both with chronic cluster headache and chronic migraine headaches. So I think it's excited. Again, this is the workshops. Feel free to send questions through my email. I'm happy to share the presentation. Again, it's on my web page, which is my name. But I'm happy to answer questions if you guys are still awake. I know it's 9 p.m. your time. So I leave it up to the moderator to decide.
Tamer, it was a great presentation. Congratulations. I will start to moment to some questions for you. André, would you like to start?
Of course. Thank you so much, Simon, and congratulations for the lecture. Well, actually, sometimes reaching AA joint disease is a little bit frustrating. What do you do if the pulsed RF failure?
For the AA, no. For the AA joint, I don't do the RFA anymore. I think the results are very mediocre. Usually I do it prior to surgery as a diagnostic test. I mean, based on the criteria of the International Classification of Headache Disorder, to make an appropriate diagnosis of pain stemming from the atlantoaxial joint is almost complete resolution of pain on intra-articular injection. Sorry. So I do this mainly as a diagnostic test prior to fusion. If the patient has significant comorbidities, not a good candidate for fusion, actually I try to target the DRG, because the innervation has to come from the C2. As I said, it's anterior ramus, not the posterior one. So I do the radio frequency ablation on the DRG, only as a palliative method. My experience that it just lasts few more weeks than just steroid injection. The good thing that you don't have to do repeated steroid injections. These are elderly, 80, 90 years old female with significant osteoporosis. So if you wanna space out the steroid injections, yes, RFA of the DRG would be a good option. I used to do intra-articular DRG, not anymore. The DRG is, we know the anatomy of it very well. We know how to target it. And the innervation of the joint has to come from the C2 level with some innervation from C3.
Lovely. Thank you so much.
Thank you, sir.
Cissa,
Hi. Well, first of all, thank you for the master class. And here I see a question at the chat, which is from Rafaela Lorena. What is the maximum volume you usually use in the C2 DRG, and what medications do you usually use in the solution?
Oh, this, yeah, good question. I failed to mention this. I was going quickly through some of the slides. The maximum is 2 mLs. Usually it's a mixture of bupivacaine, 0.25%, and dexamethasone. Usually 5 milligrams of dexamethasone. I try to avoid depomedrol or Kenalog or any particular steroids in the neck area, because there were few 10 years ago or so. We agreed that particular steroid might get into those small critical vessels and causing infarction and occlusion of those vessels. So in general, in the neck, I use dexamethasone. In this area, 1 to 2 mLs. I use even the 3 ml CZ, so I can have good control on it. 1 or 2 mLs in the area. If you use it with fluoro, it's perfectly fine. You aim like as if you are doing a lousy, like bad atlantoaxial joint. If you are not interarticular, then you are doing DRG. So just stop short of the joint. With the ultrasound, it's really fascinating because you inject, you know that you are deep to the inferior oblique muscle. 1 to 2 ml, you'll see that it raises the muscle. Actually, it pushes even the epidural space down. So both ultrasound assisted with fluoroscopy, it's perfect. If you want to do it alone with fluoro, absolutely fine.
Well, here we have another question from Natalia Moretti, who is in Canada. And do you perform a non-target blood patch if no CSF leak is found in a case of headache, or do you prefer to continue in the investigation?
Okay. This is a very challenging question. Can schedule another talk about it, but in general, I will say, I have to admit that I'm biased. I hate epidural blood patches. I call them iatrogenic epidural hematoma. You give the patient epidural hematoma intentionally, and it depends on how it's gonna heal. Good luck. I personally would do epidural blood patch only if I know where is the leak. If there's a leak, you have to patch the leak, no doubt. I mean, you try SPG for posterior puncture headache and stuff. It's a temporary measure until the morning, so you go and do the blood patch. So young patients, especially after delivery. They need to attend to the baby. They are miserable. I would do blood patch because their spine is beautiful. They don't have stenosis. Elderly patients that I did the dura puncture because of my epidural, and I do the epidural because he has stenosis, I won't do blood patch. Patient will suffer 2 or 3 days. It's fine. Unless there is no sagging on the brain. When there is hypotension, intracranial hypotension, I will strive to find where is the leak. And yes, if there is a leak, blood patch or interventional radiology, they do fantastic job now with CT guided. Even anterior epidural, because the leak usually anterior epidural, not posterior epidural. Ossified from the cervical spine, calcified disc, poking into the thecal sac, and the leak is anterior. So even if you do blood patch posterior, you need a big volume, and you don't want to inject a big volume in the neck area. So to briefly answer your question, I personally do not do empiric blood patches. I know people injecting 30 mLs in the neck and 30 mLs in the back, so they blood all the spinal canal. I'm not a big fan of this. I know those patients are miserable, but honestly, with again, if not iatrogenic blood puncture, it never cures the issue. If it's a wet tap, yes, for sure I would do it because I know the etiology and you are patching the hole. But I will strive, like what you said, I will continue the investigation. There are now dynamic CT scan, dynamic MRIs. There is fancy stuff. Unfortunately, it's expensive, but just remember, when you inject the blood into epidural, this is epidural hematoma. And if I looked at the surgical literature after spine surgery, 5 ml, I mean, patient had neurological deficit. With re-exploration, they evacuated the epidural hematoma, and in some of those cases, it's only 3 mLs. It's only 5 mLs. So imagine if you're injecting 15 ml in a neck that has already stenosis from whatever reason, because that's why they got the leak. They have spondylosis. So I would be careful. If I know the target, then I will try to inject small area. Or honestly, I work with a couple of interventional radiology. They are injecting other stuff, glue, other stuff than blood that seals the hole with CD guidance. So you can be truly transforaminal through into the anterior approach. I'm sorry, I'm biased against the epidural blood patch, so you might need to ask someone else from the group, but I just don't like blood patches.
Hell.
Hola. Hello. Congratulations. Yes. Congratulations. A really good talk. I have 2 questions for the professor. What are your recommendations to avoid complications in blocks in the fascial area? For example, supraorbital, infraorbital, submental. I want to know which size of needles do you use and the dose of dexamethasone, for example, and if you prefer to do cryo, radiofrequency, or hydrodissection. And the other question is, I want to know your opinion about hydrodissection in the greater occipital nerve. Thank you.
Oh, yeah, very important questions. For the supraorbital and infraorbital, in my previous practice, I actually had a case of disfiguring. The young girl developed a dimple, and it was blamed on the steroids, the dipomedrone. So usually in the face, we try to avoid dipomedrone. It causes lipodystrophy. Dexamethasone is a little bit better. In general, actually, we try to avoid steroids at all in the infraorbital, in the supraorbital. Infraorbital may be okay because there is a little bit of pad, but the supraorbital, yeah, it can cause disfiguring because of lipodystrophy. So if you're gonna do it frequently, definitely local anesthetic only. In this area, again, 1 ml, 2 ml, you will have a big swelling for the patient with 1 or 2 mLs. 1 ml, I don't think I can ever fit 2 mLs in this area, unless you fan it, and so some will be at the supratrochlear, some will be in the supraorbital. Yes, maybe. So I use bupivacaine, I mean long-acting, and I use dexamethasone, usually half a cc, 4 milligrams or so. If I need to do repeated injection, then definitely I don't use steroids. So this is for the face. The same for the occipital. There is few cases, and we see it a lot. Usually it's not a big deal, alopecia, hair loss from repeated steroid injection. Again, more with the with the depomedrol, the methylprednisolone, the Kenalog, rather than the dexamethasone. And when we did we just recently published guidelines for steroid injection. We recommend against steroid injection in the occipital nerve. The literature showed that it is helpful only for cluster and if there is proven entrapment. So entrapment and swelling of the nerve due to entrapment, but not for primary headache disorder. I use again small dose in the occipital, 2 mLs. You can cannulate the space between the semispinalis capitis and the inferior oblique, and I use dexamethasone. But for repeated injections, only local anesthetic. Bupivacaine, if you want a 0.25%, 0.5%, I'm not worried about intravascular escape because it's a small volume. It's a small volume. If you want to do bilateral, I know some they do bilateral occipital, bilateral supraorbital. In this case, you might not want to use bupivacaine. You want to use maybe lidocaine if you worry about vascular absorption. But I will be shocked if you have any problem because it's a small volume, unless you inject it directly intravascular in the occipital area. With ultrasound, it's very hard to believe that you will inject direct intravascular. I use bupivacaine. If you feel more comfortable using lidocaine, it's perfectly fine. It's your comfort zone. But I personally use bupivacaine, 2 mLs of 0.5% and 4 milligrams of dexamethasone per side. Repeated injection, I skip the dexamethasone. There was a second part of the question that I missed, or I captured your question correctly?
Summer,
Yes.
I'm surprised about your wine and about your wife taste of in cooking with that wine.
Don't bring this subject again. We had
Yeah,
nice discussion at that time.
yeah. I would like to ask you about some difficult cases I had when I need to make disc procedures, cervical disc procedures in difficult case, and many times I combine with the superior sympathetic cervical ganglion. I know it's better in fluoroscopy for discogenic pain treatment, and but in ultrasound for cervical superior ganglion, if you have experience if you use this kind of procedure, just ultrasound or combine two, and if you have the two treatments in your arsenal to help your patients.
The first part, honestly, I was not aware that you use the sympathetic block for cervical discogenic pain. I mean, it's a good theory, but I was not aware of this. I will tell you what I do, honestly. Personally, I have tough time identifying the superior cervical ganglia most of the time. If I do sympathetic block, the traditional way we describe at C6 Actually, we know that it's the middle cervical ganglion. And all the sympathetic innervation is coming from the upper thoracic cord, T1 to T4, through the inferior ganglion, middle and superior. So if you block the middle cervical ganglion, you block anything above it. If I want to be more specific, I found that the best thing to do is the carotid plexus at the bifurcation of the internal carotid.
Yeah.
The bifurcation of the internal carotid usually around C4, and it's very easy to see, right? You follow the carotid, just below the angle of the mandible, it bifurcates. We know that there is carotid, the sympathetic, it's a carotid plexus around the carotid sheath. So I just inject here. This is my approach, but to selectively target the superior cervical ganglion, I don't have much experience in it. Honestly, I did it only maybe 3 or 4 times, and I was not sure if I did a good job or not. So when I wanna do sympathetic chain block, selective, I do the middle cervical ganglia intentionally at C6, actually between C5 and C6. You see the groove between the semispinalis capitis and the coli muscle. No, not the semispinalis capitis. The longest coli and the longest capitis muscle. The groove between them, usually it's between C5 and C6. This will be the sympathetic chain at the level of the middle cervical ganglia. Higher, I will go for the carotid. Actually, sometimes it's the carotid sinus there. So this is the best sympathetic innervation. I noticed lots of variation in the blood pressure and stuff, which tells me that it is a sympathetic plexus. You will get it. Do you have much experience in the selectively blocking the superior cervical ganglion?
Yes, in less than 10 patients, it were difficult patients, and I used to combine ultrasound, like you said, after the division of carotid artery, and in one patient I use a neurolytic agent, and because I did one test before with lidocaine, it was good for her, and after that I used the neurolytic agent, but I had a problem with the voice of the patient because I paralyzed the vocal cord. Then I never used again, man. But I now the other 3 patients I used the stimulation together with this procedure to make sure don't have this kind of problem.
And this is for upper discogenic pain, upper cervical?
Yes.
Oh, good to know. Yes. If I may, there is a good question about cannabis and headaches. There's not much research about cannabis and headaches. I know from experience that it helps with neuropathic pain. I have few patients with trigeminal neuralgia that they had RFA, they had decompression, they had gamma knife, they had anesthesia dolorosa as a complication from the surgery. And the severe neuropathic pain, the only thing that helps actually topical THC, or even edibles. This elderly patient cannot tolerate opioids. NSAIDs are contraindicated because of kidneys issues and stuff. So I don't mind, but this is my opinion. This is not the opinion of my work institution. They are totally against cannabis in general, but this is an international conference. So neuropathic pain, yes. Some patients with cluster headache, they can benefit. Yes, if everything else failed. I do not recommend it at all for migraine headaches because I treat it as other strong analgesics. And we don't know if it will contribute to medication overuse headache or not yet. There's conflicting message. I know our friends from University of California, San Diego, they use it for migraine. They said that they don't believe that it caused medication overuse headache yet, but I don't use it for migraine headache. The patient that I have, honestly, are either trigeminal neuralgia or cluster headaches. And CBD is a different story. CBD, yes, we recommend CBD. CBD historically is valuable for neuropathic pain in general, but it's usually neuropathic pain or arthritis. But as an analgesic, especially dissociative analgesia, it's THC. I consider THC is more or less ketamine. It's psychedelic. So the indication for ketamine will be the same, more or less, if it comes to headache. So if everything failed, yes. But ketamine, we do it monitored once every month or every few weeks, or you do it in a series once a week and then you stop. The issue with THC, it's daily thing. They take it frequently. So they get into habituation, dependence, and maybe still, I'm not excluding medication overuse headache. So I'd be very cautious with THC for headaches yet. But for cranial neuralgia, persistent idiopathic facial pain, which we used to call atypical facial pain, nothing works with those patients. You want to try? I mean, no one will fault you.
Ok. Alguém da mesa aí quer acrescentar alguma pergunta, pessoal? Andrés, Cissa, Angel?
Here is another question from Javier Anton from Mexico. He says he's asking for persistent neuralgia, postherpetic neuralgia, your experience for treatment.
Yeah, those are very, very intractable patients. And unfortunately, neuromodulation does not help them. They have a honeymoon period of few months, and then actually they come for explant, whether facial or even upper cervical. We tried both over the years. The best, there is a significant component of sympathetically mediated pain. They respond very well to stellate ganglion block or sympathetic chain block, to be accurate. But the question is what you do for long term. We tried again Botox, botulinum toxin, but this area is open. It's not like the pterygopalatine fossa and the SPG. They had ptosis drooping in the eyelid for weeks. We stopped doing it for long term. Radio frequency ablation in the area, I don't have experience in it. I'm aware that people are doing it. And in Latin America, maybe I think last meeting in Mexico, someone said using it. I don't do it. Maybe pulsed, because I reviewed the case of actually fistula between the esophagus and the skin from conventional thermal RFA of the stellate ganglion here. But it was with fluoroscopy. So created a big lesion that causes a subcutaneous fistula connected to the esophagus. So it has a bad name. We do catheter, infuse it for a few days. Patient can go home with it with a portable infusion. I have done neuromodulation, but not recently because it's very difficult to get it approved with insurance. But have a very good results with the neuromodulation of the SPG, of the stellate ganglion for shingles and actually for Raynaud's in the hand. This was my two best indications. Very easy to navigate, put the lead because you can see the facial plane between the groove between the two muscles, longus capitis and longus coeli, and just change the transducing long axis. And I put it from cephalate cranial. It goes all the way down along the anterior sheet of the longus coeli muscle. But again, now, I mean, we're losing my experience in those because more recently, most of all the insurance companies stopped reimbursing for most of those innovative technologies, unfortunately.
Thank you, Professor.
Thank you, sir. Thank you.
Lesão.
Thank you so much. No more further questions.
Right. Thank you.
Assista.
Thank you very much for having me here, and sorry for keeping you late, and have a good night.
Okay. Thank you so much, Summer. Have a good night. Bye.
Thank you. Thank you.
Good night.
Bye.
Good night.